The Victor Black Masterclass presentation is brought to you by
All right.
Okay. Sawadee Cup and hello and welcome to another Victor Black Masterclass video. In today's video, we are joined with a very special guest, Dr. Michael Miletic. Michael is someone that I know through my postings on Facebook. I've been on a bit of a drive in the last few weeks about cognitive health, long-term cognitive health, and the consequential deleterious effect of enhancement practices on our brains. And Michael reached out to me and was very supportive of some of the comments I made. And I learned a little bit more about Michael. And eventually we thought, okay, this is a great opportunity to get someone on the show who's really a specialist in this area. At the end of the day, I tell everyone I consider myself literally to be just a bro, someone that's trying to learn, someone that's trying to share what I learn with others. And I think it's really important we get specialists, guys who are really king of their domain, as it were, onto the show and get their feedback and their opinion. So welcome to the show, Dr. Michael Miletic.
Thank you very much, Victor. It's really an honor and a pleasure to be here, and I've been looking forward to this.
So can you just share with the audience a little bit about your professional background? And we were talking just before the show about your personal experience within our tribal practices. Can you just enlighten us a little bit more about who Michael is?
Yeah, of course. So I started off, actually everything that I do in my practice has come about from my own personal experience, Victor. And my own personal experience started when I was 14 or 15, and I started the sport of Olympic weightlifting. Grew up in Canada, and where most people were playing hockey, and I went off to a gym and in the garage and so forth to pursue Olympic weightlifting. And back in that day, I was very determined. I had some really successes. I won the national championship in 1982. Actually, that was the year I ended up graduating from medical school. But that allowed me an opportunity to really study the use of anabolic androgenic agents back in that time.
Mm-hmm.
And those were also the days pre-testing for the most part. So very little was known about anabolic androgenic steroids except from the traditional sort of medical practices and medical researchers who were still claiming at that time that there was no effect. Well, we knew we had special we had sort of special ties as Canadians with the Australians, and we would go after a world championship or national or an international championship rather, and we would go and we would befriend the Soviets and the Bulgarians, and more the Soviets and the Bulgarians. They were much more open about things. And then we got a lot of our information from those people. So we got, they were incredibly ahead of physicians in North America at the time in terms of what their knowledge was, what they were doing, how they were doing it. And they felt very free to impart that knowledge to us. So I actually started off from my own competitiveness, in my own competitive sport rather, learning about these agents and then doing much of my own research. So I kind of was a autodidact. I taught myself most of the things because, frankly, at the time, a lot of the medical stuff we were reading was quite frankly and purely propaganda. And I didn't believe it as a medical person or as a competitor. So I was forced to do my own research, and then later on began to, as these became much more topical, of course, began to study them to a much greater degree, and then began to study it with my patients. So it's been a little bit of a journey that way, but it all began very personally.
And today you run a specialist practice in cognitive health. Is that correct?
Yeah, so I'm a neuropsychiatrist and metabolic physician. So what that essentially means is that I look at kind of a multitude of different things that comprise cognitive health, and that is, I think of emotional health. So I've done psychoanalytic training. I think of sort of neurotransmitters. So I've done psychiatric training. I think of neuroscience. So I think of the brain
Mm-hmm.
and neural networks, and then everything, all of the neural networks that go into the periphery and the autonomic nervous system bidirectionally and so on. Well, what's very interesting to me and what I have found most rewarding in my career is that everything that the nervous system touches has a system of its own. For example, the gut or the immune system, the cardiovascular system, the renal system, et cetera, are all powerfully influenced, if not driven, by the brain.
Yep.
So my field allows me to study each of those independent, independent but interconnected sort of physiologies. And we also know that those systems communicate with the brain just as much as the brain communicates with those systems. So I'm able to sort of be an integrative physician that looks at brain and body together. Great.
Awesome. Okay. So I guess I mentioned to you this before we started the call. One of the challenges for me here is I said to you, I could probably go out to dinner with you every night this week and spend 5 hours talking about this subject. And of course, the limitations of a call like this is we kind of have a limited amount of time to cover as much ground as we can. And I literally said to you, I would like, if possible, to try and really just cover a couple of key points that I think are paramount and important to getting the door open for people. Yeah, because I think that it's very possible for us to go down the rabbit hole and start talking about very specific, issues. But if people are not yet aware of the problem that we have, what's the problem we're facing, then it's very difficult kind of to get them to follow you, as it were. And I mentioned you before. Last week, I actually spent a decent amount of time on one of the leading bodybuilding forums in the world, trying to talk to people about potential toxicities, neurotoxicities, and that various testosterone analogs. And I got roundly shouted down by an awful lot of people that see themselves as the voice of experience, because they, quite bluntly, I don't think understand the problem. So if we can start with the problem, let me start with the problem. I think it's fair to say that most people are familiar with the argument about acute behavioral issues with the application of androgens. The colloquial term roid rage, or atypical behavior consequential to androgens, whatever. I would like to set that aside, because my principal concern is the long-term impact, or the long-term implications of our behaviors. Yeah. So if we can focus on more on the long-term potential deleterious effects of our tribal practices on our brain. And before we get into this, I know I don't need to say this to you. I'm saying this more for the audience point of view. If anything I say, you feel that I am incorrect, or I am being biased, or my information is misleading, please, I'm here to learn. So I know that you will correct me. I'm saying this more from the audience's point of view. One of the challenges I feel people have is they think I'm very biased about my opinions and I don't listen to other people. And that's because, quite bluntly, I don't hear other people talking about these things. So if anything I say at any point, you go, well, that's not correct, please. I know you'll do that. Please point that out to me, because I would very much like to learn myself from experts like yourself. So can you just start us off by, in a high level sense, explaining where the current state of research is in terms of potential risk to the user community from the extended application of supraphysiological androgen doses on the human brain? Where are we at? Because a lot of people would say that's speculation, that's a rat model. I hear this all the time. I show people studies, and their immediate pushback to me is, yeah, but that's a rat and we're not rats. Can you just give us a high-level summary of, so where is the current state of evidence in terms of, this issue?
Yeah, I think that's a central question, and that really gets to the sort of heart of all of this, because first of all, when people look at, I'm not going to defend rat research and say rats equals humans, but on the other hand, the rat type of research that is being done are looking very directly at receptors in the brain. They're looking at neurons. They're looking at genetic expressions. They're looking where they should be looking. Mm-hmm. And what we can get from a rat model is the exact molecular mechanism by which these compounds may be causing deleterious effects, especially chronically. And what we are trying very, very hard, I hope, as a society to do, is to avoid chronic neurological conditions. It's getting too great an epidemic, rather, that what we're looking at with dementia, what we're looking at with Parkinson's disease, what we're looking at with some of the other chronic neurologic illnesses. Now, that being the case, I think we still have some pretty good evidence of a few things here. I think that, and I'm going to be talking about this both from personal experience, from experience of myself, from experience of my teammates, because I actually had been involved in the Olympic team and in my Olympic teammates, also my patients. My patients, I have a significant proportion of which are professional athletes, a significant proportion of which have been Olympic athletes in the past. And now I see fewer athletes in the game and more athletes past the game. So it allows me a very different perspectives across the board, Victor, because of being able to see it from these different perspectives. So putting that now, if we have what you and I both know very well about the effects of the reactive oxygen species and reactive nitrogen species, and what these 17, particularly the 17 alkylated forms of the testosterone do, the nandrolones, the dianabols, the boldinones, et cetera, the higher the degree of moving away from testosterone proper and into these analogs, it seems like the greater the degree of disruption of genetic expression, as well as an increase in the reactive oxygen species and inflammation. And what we also know about the development of chronic neurological disease is that those are the two main factors, in addition to glucose, which we can get onto later, that really are the foundational causes of neurological deterioration in a middle-aged and elderly person.
Yep.
So that's
I just want to interrupt you there, because I just want to explain what that is in our language, so people can understand, because people might have missed that. So again, if I'm misrepresenting you, please tell me. So I have long been trying to explain to people that we have testosterone and we have many derivatives that have been, surprise, surprise, derived from the testosterone molecule. The purpose of those derivatives were basically to try to retain the therapeutic benefits of testosterone, but to minimize the androgenic impact so that they could be used in the androgen sensitive. Yeah, that is, I think a fair first pass statement. Yeah. And it's fair to say that when we look at all of these testosterone derivatives, it's not so much the degree of protein accretion each brings to the table that becomes the choice of compound selection, but what else they do. Okay. So it's fair to say, testosterone does this, and derivatives of testosterone tend to bias towards something else they do in the body beyond protein accretion that we might leverage for performance advantage. Now, the challenge is that each of those derivatives then in turn plausibly have greater or lesser magnitude of impact on reactive oxidant species. And there's, I think, enough evidence. Again, I completely agree that we're talking about rodent models, but I think there's enough evidence that looks at various testosterone derivatives in what would be considered comparator studies lined up side by side and saying, look, these drugs under this set of circumstances and these conditions, when compared side by side, this drug caused more, oxidative stress than this drug did at the same dose. Yeah. Is that a fair summary of what you're saying? So there is a differentiation between the various analogs and the potential oxidative stress that they cause on a milligram by milligram basis.
I think that's a critical point. In fact, I'm going to go back and forth between the personal and the scientific again, because I was in the Olympics in 1996 in Atlanta, where I had a conversation with two of the national track coaches as we were sitting and having a beer. And, you know, at that time, the only focus was on the cardiovascular side effects and the negative cardiovascular side effects of testosterone at supraphysiologic doses.
Yep.
And yes, those did occur. So they were kind of concluding, now this is in 96, so now we're talking about 25 years ago already. So they were sort of coming out and trying to convince me that nandrolone and Anabol were the safest of them, because they hadn't even started looking at the brain yet. Now, so that's point one. Point two is that we also know and that low testosterone is also, in my opinion, and in my clinical opinion, and in my clinical judgment, and in my clinical practice, low testosterone has very serious and negative side effects on the brain and heart.
I think we can take that as fact. Absolutely. Beyond opinion, that one. Yeah, absolutely. Yeah.
So I am not anti-testosterone whatsoever. However, the effects of the testosterone and the androgenic effects can be, and I think we're much further down the road, can be mitigated. The sort of water retention and the increase in blood pressure, the drop in HDL, et cetera, that we see with testosterone, we have ways of dealing with that.
Agreed.
But we also, now that's point two. Point three is that it's only become recently known through work such as yours that we're beginning to shift from a cardiovascular sort of focus exclusively in looking into the brain. And we have ways now to look into the brain that we didn't have in the 90s, for example, or in the aughts. What we're seeing now in the brains of people that particularly have been on sort of lifelong, meaning back in their teens, as we talked about at the beginning, back in their teens before their brain, while their brains are still very neuroplastic, before their brains have really fully developed, what we're seeing is that the effects of very high testosterone, it's supraphysiologic for prolonged periods of time, or the effects of the analogs of these testosterone are causing behavioral changes, cognitive changes, and emotional changes. So I look at all three of those. And when I say cognitive, I mean memory. I mean ability to be able to process things in a hurry, to be able to use our frontal cortex in order to sort of think forward in our executive functioning. By emotional, we all know what that leads to. And I'm separating these neurotoxic effects out from the potential that these are cardiovascular or cerebral vascular effects. I want to make that point clear. That I think that
can I just add something there, because that's really important. My three key messages to people is we should be looking at our brains, our kidneys, and our heart. And people tend to be obsessed about things like their hair and their liver and gynecomastia, and I'm kind of saying, well, you know what? I think those things are relatively easy to understand and very easy to manage or mitigate, because we know exactly how to do those things. We also have pathology that we can look at the liver, and we understand, stresses that we would expect to see consequential to the administration of androgens. Putting that aside, so one of the interesting points though is that a particular drug may in some circumstances prove to be better for your heart, but have an opposing vector on your brain. And this is the interesting thing. It becomes quite challenging when you start choosing compounds. You go, well, that particular drug may rank better in the safer use for your brain category, but it may well be more deleterious to heart health. Do you mean? So it's not a simple case of clear cut. This is where I start to get into conversations, about things like boldenone. Boldenone, in my opinion, we have enough evidence to say, look, it would appear, based on the evidence that we have, that it is neurotoxic, it is, kidney toxic, and it's liver toxic. So it gets a kind of across the board sort of thing. And so then you could probably put that in the first category and said, maybe we'll put that in there. We'll come back and revisit that discussion. Whereas testosterone, I think it's fair to say that at moderate doses is neuroprotective. At moderate doses, it's cardioprotective. At moderate doses, principally due to the estrogen, the metabolization of testosterone to estrogen has, estrogen is protective of our renal system against high androgen use. So you can see there are two opposing drugs that people would say, well, they're exactly the same as each other. But when you actually line them up and go through a list, well, testosterone is potentially neurotoxic at moderate dose. It's good for your kidneys because of the estrogen profile. And I would argue it's good for your heart because of the estrogen profile. And a very similar molecule, not terribly dissimilar in terms of chemical structure, cannot be considered in the same vein. So when you looked at those two drugs, it's a very easy choice. Some of the other derivatives are a little bit more complicated because they, I think Winstrol is a good example. I've seen a number of studies that would suggest that Winstrol seems to stack up quite well in terms of the cognitive comparison discussion. But of course, what it does to HDL cholesterol levels plausibly opens up a discussion about cardiovascular health.
Correct. So I think that being able to begin to sort of parse out which ones are more nephrotoxic, cardiotoxic, or neurotoxic it's critical. And there have been, I think without a doubt, testosterone in moderate doses, in part because we can control the estrogen levels and we can track them and follow them. Every patient that I have, for example, on HRT, I do labs every 3 months, like literally every 12 weeks. And I go a little bit more deeply into some of the labs I do. For example, almost every physician I know is satisfied with doing a BUN and creatinine. I am not, because strength and weight athlete or an athlete taking creatine or something such as that, they're going to run a high creatinine. They just are. And so many of these people are told that they're going into chronic renal failure. Well, there's a much better test for kidney function in terms of the nephron, and that is cystatin C. So everyone should be getting a cystatin C quarterly, every 12 weeks done. Now, what we know about cystatin C is that it actually measures nephron functioning. And when we look at these derivatives, Victor, with measurements of cystatin C as we go along, we can see clearly an increase in cystatin C indicating direct nephron damage. Now, do we have that ability to pull out something from the brain? No, we don't have that same sort of biomarker yet. Although I think we're going to have that
soon, maybe.
But what we can do is we can do very precise sorts of cognitive measurements of the brain as we move along as well when we're concerned. So my goal is to protect people. Their choices are their choices, but my goal is to try to find ways to protect each of these systems individually. And to your point, I think testosterone is the one that we can protect the most from.
Okay, so if we can talk a little bit about some of the other potential stimulatory and inhibitory inputs on cognitive health, I think it's also fair to, like, when we look at enhancement practices, the first pass conversation, tends to default to anabolic steroids and compound selection and dose. But I also think it's important in the context of this initial introduction to the subject that I am very big on trying to get guys to understand the potential negative implications of the application of large amounts of recombinant human growth hormone and insulin in terms of creating insulin resistance and the potential impact on the brain from that. Can you just draw these threads together for a little bit and give us your opinion? Would you agree that the potential negative impact of insulin resistance with aging and cognitive functioning, and the potential practices that we see where guys have horrible insulin resistance, where they're using very large, like 8-10 units of growth hormone a day, 50 to, I'm not joking, 150 units of insulin a day. And the reason they use so much is because they need to use so much because they're so insulin resistant that their bodies simply no longer respond to a little bit sort of thing. Would you agree that that parallel that I try to draw between those two is a fair one, that's not a good thing for our brains?
Well, the neuroscience is telling us now that, in fact, some of the neuroscientists are saying that dementia, Alzheimer's disease, is type 3 diabetes.
Yep, sure.
And what they mean by that is that there is a direct correlation, like literally direct. If you graph it out, and there are two parallel lines between insulin resistance and amyloid plaque formation.
Mm-hmm.
So in other words, what you're referring to over time, as we increase our insulin resistance, we are literally depositing more and more plaques and then ultimately tangles in our brain, which we know are the sine qua non sort of markers of Alzheimer's disease. So there's absolutely there's no doubt about that anymore. There's no question that's been proven over and over again.
Mm-hmm.
The other thing is the other factor that you mentioned, and I think correctly, is glucose levels. And what we also know is that the higher the IGF-1, the higher you're pushing up blood glucose, and you're increasing insulin resistance the greater the IGF-1 goes.
Correct.
On the other hand, you don't need it is useless to be pumping high doses of growth hormone into your body, because you are causing all of these negative side effects, but B, you've saturated receptors of any sort too.
Mm-hmm.
And so, if you're, I think of all of these hormones as a key going into a lock, which
Mm-hmm.
is the receptor. If your locks are all full already, why are you pouring more keys into it?
Mm-hmm.
I mean, it doesn't make any physiologic sense whatsoever. This is an emotionally driven decision to be pumping these amounts of HGH into our bodies. It has
Mm-hmm.
nothing to do with science.
Mm-hmm. That's interesting. Can I get you to expand on that? Because one of the great debates that I've been trying to correct for many years is the fact that androgen receptors downregulate the presence of androgens. In fact, the complete opposite is true. When you introduce androgens, you upregulate androgen receptor expression. I'm not familiar with the situation. It's an interesting thread. I've never bothered to pull on it. It's fascinating. So you're basically saying that growth hormone, IGF-1 receptor levels are neither upregulated in the presence of IGF-1 nor downregulated. They're relatively static in a genetically unique individual. Is that correct?
They're relatively static unless we begin to look at epigenetics. Now, epigenetically, over time, we don't know what that's going to turn out to be yet.
Okay.
But if you look at present state moment, there doesn't seem to be either an up or down regulation from the most that I've been familiar with.
Mm.
If there's any other articles out there, please send them along. I'm interested to learn the same way as you are.
That's interesting. Yeah, cool. Okay, so far we have, I think someone made a comment on a post that I made on Instagram that, they were kind of saying, okay, well, Alzheimer's disease, as you said, is type 3 diabetes. And you kind of came in and made a comment to say, yes, but that doesn't take away the discussion about the potential negative implications of the applications of androgens. So they are two very important but distinct pathways that we need to consider in this conversation. I don't think it's right to say, well, Alzheimer's disease is type 3 diabetes, so it's all about the growth hormone and the insulin. I think it's fair to say these are two very distinct pathways that we need to respect both of those. Yeah. Yep. So the third thing I wanted to talk about was, kind of like this discussion about inflammation and the management of inflammation. There are a number of drugs that I'm a big fan of, sort of thing. I like them. I think it's fair to say there's a reasonable amount of positive research in terms of the clinical literature. I mean, the drug telmisartan, for example, Mecartis, is a drug candidate for Alzheimer's disease. There are many in the pipeline, of course, and that's not to suggest it's going to come out the other side with glowing, but I think it's fair to say it's on the table. Yeah. And one of the reasons that I favor drugs like metformin and telmisartan and things like this is the potential for them to contribute something to the management of inflammation, as well as, in the case of telmisartan, insulin management, and metformin the same. Can you comment on the implications of inflammation and brain function and the potential stimulatory inputs from our practices on that? What would you see as the key takeaways in a first pass discussion regarding inflammation?
Yeah, so I think inflammation is what I would put as the key to brain health and or degeneration over the long term. Inflammation is critical, and you can't speak about glucose, or you can't speak about these other compounds that we were talking about without talking about inflammation.
Yep.
an inflamed cell, an inflamed neuron, an inflamed astrocyte, an inflamed oligodendrocyte, and so on is a very dangerous one because it will begin to literally burn itself up. So when we introduce reactive oxygen species and reactive nitrogen species into the brain, this can be, there can be so many causes for this, and this is part of what's sort of interesting for me in my practice. I look at everything from, metals to toxins to pollutants to cortisol to stress. We can't have a conversation like this without bringing stress into
stress, correct, agreed, yes.
And the impact of stress in addition to some of these other extraneous things that we put into our brains and bodies. So when we look at metformin, of course, we're looking at glucose and we're looking at insulin resistance. When we look at the people that are looking at, for example, resveratrol and pterostilbene together, they are looking at histone proteins, but they're also looking at inflammation there. And if you're looking at, what was the telmisartan? Telmisartan I use with just about everybody prophylactically that is taking an anabolic agent now.
Yeah,
and
that's interesting. I didn't realize that we're on exactly the same page there. Yeah,
exactly, Victor.
Cool.
And I also use that for anyone with insulin resistance at this point.
Yeah. Can I ask your recommendation? I very often asked for dosage recommendation, and my typical recommendation is to start at the minimum clinical effective dose, which seems to be 40 milligrams a day, and titrate for effect. Would you agree with that, or do you tend to start at a different level?
Yeah, I start with 40 as well, and then I'll go to 40 BID. I think more than that, you probably aren't getting much more effect.
Okay.
With the telmisartan, and telmisartan has a real beauty to it where we know it's impacting inflammation, and for those I measure IL-1, IL-6, the interleukins. I look at HSCRP and all of the other ones that may go with that. Long-term ferritin, for example, is another one to be looking at for long-term inflammation, hemoglobin A1C, etc. But the telmisartan has a nice, very nice additional thing about it, and you can measure blood pressure on it because it's an ACE2 inhibitor, so therefore we can look at the effects on blood pressure, and we can follow cystatin C in order to sort of get a rough dosing schedule for that. And so I think this has not been proven in any sort of studies that I've found, but I think from my clinical experience, it involves tens if not hundreds of patients, that if we cystatin C again with blood pressure with telmisartan dosage will give us a pretty good idea if we're keeping inflammation under control too. Understood.
Cool. All right. So we're coming up on just 50 minutes, and I'm extremely mindful of the fact that most people at 1 hour tend to glaze over. So what I would like to do, if I can, is let's just circle back around and have a summary of where we're at the moment, and then maybe we can put this content out and let people marinate on a bit. And there's going to be a certain number of people that would like to go further, and if you're generous enough with your time, maybe we could open some of these doors and dive a little deeper, because as I said, to me this is a fascinating, massively under-discussed subject in our community that we should be talking more about, and it's very hard to find individuals with personal practical experience and clinical experience as well. So let me just see if I can summarize. So I think it's fair to say that what we discussed was that this issue of the potential long-term deleterious effect of our behaviors on our tribe this is not maybe, in my opinion, and from what I understand from what you said, that we're in the era that says, look, the amount of evidence that we have that we should be looking at this with real concern is beyond it's a rat model. It's into the domain of like, yeah, you need to spend some time. If you're going to expose yourself to these behaviors, you need to spend some time considering the potential negative consequences on brain health from long-term exposure. I think it's fair to say the younger you start, plausibly the greater the risk. Yeah.
Correct.
The mitigation strategy at first pass, because I have a very complicated mitigation strategy, but if I did the first thing, I would argue that compound selection dose has to come first. just the idea of using the smallest amount of anything that we can use at any time, hopefully just makes logical, rational sense. It doesn't matter whether it's growth hormone or insulin and the consequential elevation of insulin resistance by using too much. It doesn't matter whether it's testosterone. If we look at it in the best possible light, one could argue that if you're a hypergonadal man, introducing some testosterone to your system is probably plausibly neuroprotective and doing you a world of good. I would argue that there's enough evidence that supports growth hormone and IGF-1 levels as being cognitive protective up to a threshold dose that whereby once you cross that threshold, very much like testosterone, you reach a curve and you start heading downhill from that. And that's principally a consequence of insulin resistance that tends to kick in at about 3 units a day, in my experience, anyway, in larger men. So we have compound selection and dose. I guess I just want to circle back on that idea of, okay, so we have a number of different potential analogs of the testosterone molecule that we could choose, derivatives, as it were. I would argue that testosterone at moderate doses appears to be neuroprotective, kidney protective, and cardiovascularly protective compared to a hypergonadal state.
Correct.
I would argue that the estrogen that's metabolized from testosterone provides us some protective benefits against elevated androgens as a whole. Yeah.
Yes, and just a quick point. I don't mean to interrupt you.
No. I'd love to get that. Yeah, please.
Yeah. So with respect to that, there are some practitioners or even some people that are non-practitioners that immediately jump in and want to give aromatase inhibitors. So, okay, if you're going to do that, tell us why and tell us where your cutoff is. I feel that for males 30 that are using testosterone or its agents, a little bit higher estrogen is a little bit more protective. That is, I run it between 30 and 40, 45, rather than these people coming in with less than 20. I think that's dangerous territory for a number of reasons. So I use very sparingly and measure estrogen, measure ultra-sensitive, by the way, ultra-sensitive estradiol, not just asking for estradiol because you're not going to get the right amount and you're not going to get the right quantity. But keeping that between 30 and 40 is going to be very protective of all 3 of those body systems.
So can I ask you, just this is not this conversation, but I'm interested in your opinion here. So I take the viewpoint that says, look, estradiol metabolism from testosterone is rate limited by the available pool of aromatase enzyme. Yeah. And so it makes kind of sense to say, as you raise testosterone levels, we would consequentially see an elevation of estradiol, but the ratio between testosterone and estrogen tends to diminish over time.
That's correct.
And so I don't see the point of even modulating or blunting estrogen in any way, provided you're not experiencing any what I would call estrogenic related side effects. Just let it go. Like, by all means, if you have a complaint, let's hear the complaint. And the problem is, for me, often people say it's things like, well, water retention, and I would argue, but that's a consequence of the elevation of angiotensin 2 and elevation of aldosterone. That's not estrogen. That's something else. So would you agree that if estrogen effectively is rate limited by the amount of the available aromatase enzyme, that if you raise testosterone levels, and provided you are not experiencing any estrogenic related side effects or any DHT related side effects, that there's really no cap on how much estradiol you should have for a man that has massively elevated androgens? You should let your body determine how much estrogen it wants to produce, you know, rather than getting in the way and inhibiting that process. Is there,
so always I'm sorry. There's always, there's the science, which you've just kind of delineated very, very nicely, Victor. And then you've got individual variation. And the reason I say 30 to 40 is that there are certain patients, and maybe I see more of them than usual, but that develop gyno and are very upset with their gyno. So those are the people, and it's for that reason that I try to keep the estrogen from going too high.
That's it.
But in principle, if you don't have the susceptibility to gyno, and if you're, I also measure PSA, by the way, and I measure free and total PSA, because, you know, as we know, testosterone and its derivatives can cause BPH, but we also know that there's no link at all between testosterone and prostate cancer. However, in my opinion, estrogen has a greater impact on the prostate gland and on hypertrophy than testosterone does.
Yeah, no,
So I
absolutely.
do follow these other things as well to look at the particular sensitivities of people.
I understand.
So
I
in
think
general, I would go ahead.
so
Sorry.
I think the point of separation would be there may be the people we are talking to, because of course my model would be, so we start off at a clinical dose of testosterone and titrate the dose to the point whereby a genetically unique individual can tolerate however much testosterone he can tolerate. In my experience, that's somewhere between 300 and 400 milligrams of testosterone a week. Most men can tolerate that. And then the logical thing to do is start walking in a drug that does not convert to estradiol or does not convert to, and obviously the consequence of that behavior means that the androgen to estrogen ratio is actually improved, and gynecomastia there is dealt with by the modulation of the ratios, whereas I'm assuming that many of your patients are not bringing the secondary drug in. They're just bringing the testosterone in, yeah?
Yeah, and as a physician, obviously, I cannot I cannot be prescribing super physiologic doses of this, but I can be managing patients who do that on their own.
I understand.
And so the people you're right. I'm referring to a specific and select group that I may be giving HRT to that has specific genetic sensitivities, which are going to be different from a professional athlete, for example.
I understood. Okay, so if we then just get back to that point I was making in summary, was I think it's fair to say this is I think this is beyond discussion, but as I said, whenever I attempt to reach out to the wider bodybuilding community, I get hammered every time I do it. And that is, I believe very strongly that all of the different derivatives of testosterone need to be viewed through the lens of saying, look, all these drugs are not the same. The risk profile is not the same. No. And the primary issue that I identify is the difference in oxidative stress that these different derivatives appear to create. Yeah,
correct.
And in my opinion, there are certain drugs that are better tolerated than other drugs. There is oxidative stress. I think so. Let me summarize. I'm not for one moment saying, look, you can take as much testosterone as you desire and there's no consequence. I believe all androgens, once you cross super physiological range, need to be viewed through the filter of saying potentially neurotoxic, potentially liver toxic, potentially, all of them should need to be viewed through that filter. But I would argue that different analogs are plausibly more or less toxic than other ones. And different analogs are potentially more toxic on different organ systems. Different androgen toxicities are implicated. So the selection compound process then begins once I'm saying, for people that are interested in safer use, you should start with testosterone because it appears to be the most benign of the androgens that we have exposure to, and use as much of it as you can tolerate without experiencing estrogenic or DHT-related side effects. At 300 or 400 milligrams a week, I'm completely prepared to say there's some measure of oxidative stress involved, some. Yeah.
Yes.
And then what I would say is let's start walking in drugs that have the next best safety profile, as it were. And my argument would be that's not drugs like Boldenone or Debol. They probably have the plausibly worse profiles based on the evidence that we have today. You should probably start with a DHT derivative. It is my opinion that probably the oral DHTs like Winstrol are more neuro-friendly, friendly to the brain based on the evidence that I've seen. But unfortunately, they have the impact of really demolishing our HDL cholesterol levels and raising our cardiac model. And so the compromise begins. And so saying, well, okay, so let's go with the DHT derivatives like Masteron and Primobolan and Anavar that don't have such a profound effect on cardiovascular health. It's a compromise between the two. Yeah.
Everything becomes a balance, and every individual is unique also, Victor, because I've seen, for example, Winstrol having neuroprotective effects, but not a terrible effect on HDL, for example, with certain people. So I think the point is well taken on your part. And the only other part I would add in addition is always get labs. So the part that I have difficulty with are people that are out there being their own experimental animals. They put down rats as experimental models, but then they use themselves. And that's just potentially self-harming. Find a doctor
Yeah.
that is sympathetic with you and understands the science and then measures. And if you put what you're describing in terms of your protocol together with a physician that will measure and keep you safe, then you are taking care of yourself in the long term.
Correct. Now you provide consultation and services in that regard. Is that correct, Michael?
Correct. Yes.
Yeah. Okay. So can you tell us a little bit about your practice? Your where are you situated? You're US based. Agreed. Yes.
Yeah, I'm US based. I'm a little bit north of Detroit in Michigan. But one of the things that COVID has done is allowed us to really expand our virtual practices. So I do Zoom consults literally around the world.
Yep.
And fortunately, I have in North America, I have both Canadian and American citizenship and licensing. But what we do for people outside of North America is connect with physicians. I send the lab requisition that I would do. People take that to their GP or to whoever their primary care person is, get the labs done, have them sent back, and then we work virtually. And it's pretty seamless at this point.
Yeah, that's awesome. So where can people reach out? I mean, you have a social media profile and you have a website. Can you just,
Right.
I'll make sure they're listed under this video. Can you just tell us what they are verbally here for now? Yeah.
Yeah, the website is the militiccenter.com. Just no spaces in between.
Yep.
And my email, let me ask my CEO who's sitting here. Because she put everything together. That's my wife, by the way. What's the best contact place?
I would say through Instagram.
Through Instagram.
Through
Yeah,
Instagram. I'll make sure that your Instagram and your website are glued on right now. I'll glue them up there so everybody could see them as they're watching the video.
Perfect.
So, cool.
Okay.
Awesome.
Yeah, that's perfect because Instagram I know how to run.
Yeah, no, great. Awesome. I can not thank you enough for taking the time to come and talk to us. I very much appreciate it. I guess I'm going to be very cheeky. And as I said, in a couple of weeks' time or a couple of months' time, whenever you have an available slot, I'd love to get you to come back on and maybe we can deal a little. I mean, I'm sure there's people out there that would like to get into the whole neurotransmitter discussion and the various derivatives and we can get into the whole, as you said, the gut brain axis. And
Sure.
I think there's just, 2 or 3 or 4, calls that we could spin from here. I think it was very important though, to place a flag in the sand and say, listen, this is not, we're not messing around here. This is not, it's not Victor's nut job conspiracy that these drugs are bad for your brain. There is good quality evidence, and professionals in this space are concerned for our tribe in this regard. So I think this was a very good first pass. I think a lot of people go, okay, so clearly this is a space, this is an area I need to pay a little attention to if I'm going to expose myself to these compounds.
And just a quick word for your audience, Victor, if you don't mind. Going into I purposely stayed away from all of the neurotransmitters and the cellular biology. Would be happy to do that in the future. Would be happy to do Q&A. Where I really feel like I excel above other people is that I'm able to do an integrated approach, and would love to discuss that with you at some time.
Sure.
But what I find a little bit disconcerting with a few of the people that react negatively against you, no one is thinking as forward ahead as you are. No one online that I have found has the sensibility, the practicality, and the sort of forward-looking care and concern that's science-based, that's talking about this question out there. And honestly, I think you should be getting more respect for that rather than the blowback. And the people that are
I get called arrogant a lot because I'm the only guy saying that you can't be the only one that's right. Like I don't think I'm arrogant at all. I'm just concerned for people's health. So,
I think you're a pioneer. I don't think you're arrogant. I think you know your stuff. And I think you're speaking directly on point to people, and people should be listening.
Thank you. It means a lot to get feedback from. I have a number of mentors, and I can very much see you fulfilling that role in the future if you're generous enough with your time. I have a number of people, and they, it's nice to get that feedback, because sometimes I feel like I'm the lone voice in the wilderness saying things, and I'm sure you understand. you begin to question, like, have I got the right end of the stick here, sort of thing. So it's nice to sit and listen to someone that has far more than I do, and like most of what you're talking about, there's merit to. So yeah, thank you. I appreciate that.
Thank you, Victor. Anytime I'd be happy to jump on again with you. And again, much respect to you.
Lovely. Okay. Thank you for joining us, and we'll see you at the next Victor Black Masterclass. Sawadee ka.
The Victor Black Masterclass presentation is brought to you by